So I am going to change directions a little bit. I'm not a surgeon. I'm a medical oncologist. I work together with the surgeons in the goal of improving overall outcome. I'm not a replacement for the surgeons in any respect. It's extremely pleasing to be able to see everyone meet here. I've been really wanting to get a support group together, triangle-wide for a while, and I'm hoping after we meet with the panelists here, the survivors, who I think are probably more important than all of us combined talking, I think it's immensely important and valuable to hear from other people experiencing the same disease. I would love if there's people that are really interested in helping get a support group started, that maybe I can touch base with some of you. All right. So that being said, I'm going to talk today about chemotherapy for muscle-invasive bladder cancer. Okay, so just a little review. I think we've seen this diagram a couple of times today, and this is really, in my mind, pretty important when we're really making the distinction of what stage the disease is and planning on moving forward with treatment planning. Again, what I am talking about right now is muscle-invasive bladder cancer. Up to today, there's no evidence that chemotherapy is of value in patients who have less than muscle-invasive disease. So I'm really talking about patients who have involvement of the bladder cancer that's at least into the muscle, if not deeper. And so again, this is kind of the bladder being taken out and opened up, and this is just a schema where we talked about, I like to refer to these kind of more as warts. They're superficial, they're annoying, they tend to come back. But as bladder cancer, again, develops the ability to invade deeper into the bladder, that's where it really becomes a problem. And we know that once it invades into the muscle level, so this is the T2s, T2A, T2B is just the depth of invasion into the muscle. T3 is actually into the fat surrounding the muscle layer, and then T4 is actually out through the bladder, that the risk of disease spreading to distant organs and actually becoming a fatal disease is much higher. So again, to remind you, 75% of patients that are diagnosed with bladder cancer are not going to have muscle-invasive disease. And again, urologists are really the primary physicians that manage these patients. About 25% will present with muscle-invasive disease at diagnosis, and that is really becoming a multidisciplinary treatment with urologists, medical oncologists, and actually bringing in nowadays the thought of bladder preservation with radiation oncologists in very select patients. Additionally, as we've heard today, there are some patients that are initially diagnosed with non-muscle invasive disease, where the disease will progress to muscle-invasive disease, and that's really where I come in. So why do we use chemotherapy in bladder cancer? I think there's really, in my mind, we divide it into two different reasons. One is to improve outcomes in patients with localized muscle-invasive disease. So what do I mean by that? These are patients that on diagnosis, usually by transurethral resection of the bladder tumor, on pathologic review, the tumor is invading into the muscle layer, but when we image patients with CT scan, bone scan, we don't see any evidence that the disease has spread outside of the bladder. So it's a localized disease. Once bladder cancer leaves the bladder and spreads to distant lymph nodes, to lungs, to bones, to liver, at least today in 2010, this is not a disease we can cure. And so in that setting, we use chemotherapy to improve both quality as well as quantity of life in patients. And I know the idea of chemotherapy, you probably asked me, how can you possibly improve quality of life? But you actually can in controlling symptoms caused by metastatic disease. So systemic chemotherapy, what I'm referring to is chemotherapy that is actually given through the vein with the goal of the chemotherapy being delivered to any cells in the body. This is in contrast to what you have heard earlier, where there's chemotherapy placed into the bladder, which is really the intent of that is that it not be absorbed into the body. We can use it perioperatively. So again, I'm talking about patients who have muscle-invasive disease and no evidence of spread anywhere else. And these are patients that we consider curable. Not every patient will be cured of their disease, but that is our goal. We can give chemotherapy before surgery with the goal of then giving surgery with performing surgery with curative intent. That's referred to as neoadjuvant, or we can give chemotherapy after surgery done with curative intent, and that's called adjuvant. So neoadjuvant basically just refers to the timing before surgery. Adjuvant refers to the timing after surgery. There's a small number of patients that will receive concurrent chemotherapy, and that is in general given with radiation therapy. We know that radiation therapy alone for muscle-invasive disease is not adequate to control the disease, and so we do give chemotherapy to help the radiation work better, and that is known as concurrent. And there are some protocols where we do try to preserve the bladder. So patients are treated with a very intensive regimen of chemotherapy in combination with radiation therapy with the goal of keeping the bladder. There's a select group of patients that this is going to be appropriate for. These are usually patients with very low volume tumors, so smaller tumors. Patients that don't have involvement of their ureters or more bulky disease or a larger amount of disease. And patients are treated with chemotherapy and radiation therapy and then followed up. What I counsel patients on is that this is an option. However, about 30 to 50% of patients will ultimately still have to have their bladder taken out, either because, number one, radiation plus chemo is not adequate to control the disease, or number two, it controls the disease for a period of time and then the bladder cancer does recur, either in the same location or in an alternative location. So this is an option, and we didn't have time today to include a bladder preservation, but it is something I do counsel patients on. And then again, palliative is when you're using chemotherapy to control the disease, to try to get the disease into a remission or to stop growing for a period of time. Again, with the goal of improving quality as well as quantity of life. So I'm going to take a minute and focus on the perioperative chemotherapy. And when I'm talking about perioperative chemotherapy, I'm really talking about using cisplatin. There's multiple ways you can make cookies, and there's multiple regimens that we use for chemotherapy, but in the large trials to date, the benefit associated with perioperative chemotherapy has really been with cisplatin-based combination chemotherapy. Now, not all patients diagnosed with bladder cancer will be able to receive cisplatin. If you have some heart disease or if you have renal dysfunction or other problems, you won't be able to receive cisplatin. That being said, carboplatin is used, and so I don't want to say that if you can't use cisplatin, you should never receive perioperative chemotherapy, but we certainly don't have the data to show it is as beneficial and in general is not used as much. So why do we use chemotherapy? If you can just have your bladder taken out, why in the world would you want to get chemotherapy as well? Well, I always tell patients because you want to see me, but I guess that's really not the answer. This is just a graph showing some large surgical series that have been done in long-term follow-up in patients who have just had their bladder removed. And this is at 5-year survival, so patients alive without evidence of disease recurrence or progression after they've had their bladder taken out. And when we talk about organ confined, we're talking about the T2s just into the muscle, whereas extravesicular, that's the T3. And node positive is at the time their bladder was taken out, there was involvement of the lymph nodes. And you can see that for patients with just the muscle invasive component that hasn't spread into the fat or beyond, that outcomes about somewhere between 70–75% of patients are still alive at 5 years, which is pretty good, however, not good enough. But as you can see, these numbers substantially drop as the disease is higher risk. So there's involvement of the fat, there's involvement of lymph nodes. And so we as a group looked at this and said, okay, this is pretty good, but can we do better? Now, when patients die of bladder cancer after their bladder has been removed, it's usually because the disease comes back and it spreads elsewhere, so to the lungs, to other lymph nodes, to the liver. And so we said, okay, if the bladder's been taken out, obviously some bladder cancer cells had to have been left behind. So if we give chemotherapy, can we kind of clean up any cells that have spread that we simply cannot see with scans today? our imaging has become pretty good. We find little nodules in lungs and things that we've never been able to find before, but it still takes millions of cells to show up on a scan. So if you have a few cells, even a few hundred cells or a few thousand cells that have escaped the bladder and have gone to lymph nodes or into blood vessels, other places, you're not going to be able to see those on scans. So the data is actually best for neoadjuvant chemotherapy, although I have to say that this is a little bit controversial. I believe that we as medical oncologists and urologists get along very well, and we agree that chemotherapy is a good addition to bladder cancer surgery for muscle-invasive disease. However, there's definitely a disagreement whether that treatment should be given before or after therapy. The reason why I say it should be given before is because we have a large phase 3, which is kind of the best kind of clinical trial that has been done, randomizing patients. So half the patients got their bladder taken out, half the patients got chemotherapy and then got their bladder cancer taken out, and they did better, okay? In the adjuvant setting, so chemotherapy after bladder cancer, the trials were much smaller and they weren't as well conducted. So we just don't have as good of evidence. That being said, we've tried to get through those shortcomings by combining the data from all of those different trials. And when we do that, we certainly see that there is a benefit after chemotherapy as well. So it's definitely not wrong to do it before or after, but I do favor doing it before based on evidence-based medicine. So again, are there theoretical advantages of doing chemotherapy before surgery versus after? I think the most important, in my mind, is treatment of micrometastatic disease. So these are possibly the bladder cancer cells that have escaped the bladder and are somewhere at a distant site. If we can give patients chemotherapy early and start to control these cells, that I think is an advantage. We have shown that chemotherapy is better tolerated before surgery. I think as you have heard today, a cystectomy is not a trivial procedure. It is a very invasive surgery. That being said, patients can do very well with it and can do very well after it, and I think you're going to hear from a number of patients today that will tell you exactly that. But there's no doubt that it is hard on your body, and so getting chemotherapy afterwards is definitely more difficult. We have shown that if we give chemotherapy after compared to before, that we have more difficulty getting the drug in afterwards. Again, it's related to it overall being tolerated better before surgery. And so if we give it after, we definitely have shown that we can't get as much chemo in, and that can definitely be detrimental. Neoadjuvant chemotherapy can also help us in that you can determine how sensitive the tumor is to chemotherapy, and it can be helpful in making future decisions down the road. Disadvantages. Clearly, there are going to be disadvantages. So some patients' cancers are not going to be responsive to chemotherapy. And so if you're taking 3 months to give chemotherapy and the cells are resistant, then you are certainly risking delaying the surgery, which I argue is still the most important component of treatment for muscle-invasive bladder cancer. There's also the potential that side effects from chemotherapy can either lead to delay in surgery, which again is the most important part, or can result in more complications either during surgery or after surgery. Now, in the large clinical trial that I talked to you about, although we were worried about this, we really didn't see it. We showed that there were really no increased complications in patients that received chemotherapy before surgery, and they did just as well as the patients that did not get chemotherapy. As far as tolerating therapy, complications in surgery, complications immediately following surgery. So why do it after? Again, I think the biggest advantage is you don't have any risk in delaying surgery. The other argument that's commonly used is that you can use the pathology results. So when you take the entire bladder out, you can see exactly how much cancer there is. We're not very good when we take just a biopsy and we examine patients and we look at their scans at saying exactly how much of the bladder is involved, how deep is it involved. We may think it is only involving the muscle, and we find out actually that it's into the fat and some of the lymph nodes. So if we know exactly what we're dealing with, we can look at hundreds of patients that have been treated previously and estimate your risk of recurrence or your risk of dying from bladder cancer, and really select the patients at highest risk to receive chemotherapy and the patients at lower risk to say, well, maybe you shouldn't get chemotherapy. Again, we're not perfect right now, and I don't think that we really can tell for any one patient with muscle-invasive disease whether you should or shouldn't get chemotherapy. There's clearly patients that will not have any cells that have spread to their bladder, and they're not going to benefit from it. There's clearly some patients that their cells are going to be resistant to chemotherapy, and they also are not going to have benefit. Again, the major disadvantages for doing the therapy after surgery is the clinical trial evidence is not as strong, and again, it's more difficult to get drug in. Now, palliative chemotherapy is used for patients where we know that we cannot today cure their bladder cancer. So these are patients, when you scan them, you see that there's obvious evidence that the cancer has spread to another organ, not just the regional lymph nodes, the lymph nodes kind of around the bladder, but lymph nodes that are farther away. The lung, the liver, the bone is the most common places. And again, the goal is to improve quality of life and quantity of life. And yes, quality of life can be improved with chemotherapy in that you're controlling the cancer itself, and therefore symptoms such as weight loss, fatigue, pain, other problems can be helped by giving patients chemotherapy. There's several different regimens that are used. The most common that you're going to hear about is a combination called GC, or cisplatin, or its cousin carboplatin in combination with gemcitabine. MVAC is another regimen that you're going to read about quite a bit if you look on the internet, but it's really not used very much today because it has been shown to be more toxic and not any better than the combination of gemcitabine and cisplatin. Now, one of the areas that we need to really improve on in bladder cancer is what do we do after frontline? So these are patients with metastatic disease. They have been given chemotherapy, and either they don't respond or they respond for a period of time and then their cancer progresses. In other cancers, breast, lung, colon, cervix, just about every other type of cancer, we do have second-line chemotherapy, which has been proven to be of advantage. In bladder cancer, there really is no standard therapy. The good news is that since there is a role for second-line chemotherapy, drug companies are now seeing that this is an avenue to be able to get their drug registered. So bladder cancer is finally getting attention from some of the pharmaceutical companies, and some clinical trials are coming down the pipeline over the last year, actually looking at second-line treatment for bladder cancer. And I think that's pretty exciting that we're finally being recognized by drug companies. There's no second-line standard therapy. There is a drug called vinflunine, which has been approved in Europe. This was compared to best supportive care. Basically, patients either got vinflunine or they got kind of a placebo. It did not show a survival advantage, so in the United States it was not approved. However, it was approved in Europe because it did shrink the tumor in some cases. It did increase the time until the disease progresses. In the United States, we most commonly use the taxanes, either paclitaxel or docetaxel. We also have some evidence out of the Hoosier Oncology Group, which is a group out of Indiana and some of its sister institutions using Alimta, which is a drug that you might hear about for lung cancer, and there has been some evidence of benefit with Alimta, again in response rates and time to progression, but not survival advantages. What do we have coming up as far as clinical trials, since there really isn't any standard therapy? Within the next 2 weeks, we will be having a trial looking at a novel tyrosine kinase inhibitor that also targets FGFR, which has been known to be a problem in the non-muscle invasive disease and non-invasive disease, but we're realizing that it may also be important in muscle invasive disease. And so we're excited about looking at whether that drug is going to be efficacious or not. We have good scientific evidence that it may be. We're also going to be opening a trial within the next couple of months looking at Taxotere, the therapy that we commonly use second line in combination with targeted therapies, looking at inhibiting angiogenesis or blood vessel growth. And cancer cells need blood vessels to grow. And we also have some phase 1 trials. So these are trials looking at new drugs, and they're intended for patients who have progressed through all standard therapies. And we do have some phase 1 trials that we have open for patients with bladder cancer who still have a good performance status, meaning they're still getting around and they're functioning and doing quite well, and good organ status, meaning their kidneys are working well, their liver's working well, again with the goal of trying to improve quality as well as quantity of life. I'd like to go ahead and stop now and allow some time for questions.